which are the patients which will do best with Contoura as compared to a, say, optimized LASIK or a Smile or something else? Like everybody will not get benefit from Contoura, right? I mean, which?
So I think it is very important to know where you will not do a Contoura rather than where you would do a Contoura. If there is a difference in, axis deviation between your manifest cylinder and your measured cylinder of more than 10 degrees with the astigmatism of less than 2 diopters, then of course, those are the cases which may not do that well. And likewise, if your cylinder is more than 2 diopters and the axis deviation is more than 5 degrees, then again, those are the cases which may not do too well. So I think it is very important to know, like I said earlier, two things are very important as far as Contoura Lasik is concerned. One is which cases you don't have to do, and two is, I think, the capturing of the data is most important thing. Everything, even the smallest detail, even the smallest lapse in that can change the capturing of the data. So your tear film has to be absolutely adequate. Your entire surface has to be captured. So these are the two things which are essential when you are planning Contoura.
Thanks, Namrata. And any quick comments from Tityal sir, like how he chooses between, Smile. He does a lot of Smile as well, and how he chooses between various procedures that he offers at AIMS, that which procedure to offer to the patient.
Gaurav, it all depends on how our patient perceives the workup and counseling, because as far as LASIK and Smile goes, you know that indications, the profile, the amount of tissue removed is almost similar. So it is how we have seen our patient and how they effectively come out with our procedure is important. And what I see now, Smile procedure which we do in our patients, the outcome is very predictable, which was a concern to begin with. Many people had raised question at that time, delayed recovery, which is not true as such. With the modified parameters, we have to understand what your machine's requirements are, what are your parameters, and the results are very good. Given an option, my first preference for my patient will be a Smile procedure for all cases suitable for laser refractive procedures. And the second priority would be those patients who cannot afford, because price is a little different in our place also. Smile is almost double the cost of a femtosecond LASIK in our place. So that may be sometimes a criteria for a patient. But given an option, Smile is preferred always because of the surgical advantage which we feel as such, and as well as the post-op results have been fantastic with these cases. As far as Contoura vision is concerned, number of patients are not very, very high, because as Dr. Namrata rightly pointed out, not many patients will have a suitable, topological parameters to be taken up. But those cases where we have a matching, manifest refraction and the Contoura, this topological refraction in terms of cylinder amount and axis do better. But more importantly, it is the surface irregularities measured by wave front assessment. Those patients would do better with Contoura vision compared to the routine optimized treatment for these patients.
Thank you, sir. Thank you. Thank you so much, sir. And thank you, Dr. Namrata and Tityal, sir, and Alcon for, having this session with us and sparing your valuable time for Uttarakhand. And we are really grateful. Can you please tell us about the patient, Dr. Namrata? So yes, we are planning to do a Smile procedure here.
Yes. Good morning, everyone. Here we are starting a live surgery session from Drishti Eye Institute, Dehradun. So the patient that we're planning for the refractive surgery is a 27-year female who's been using spectacles since past 15 years. She's a nurse by profession and is an occasional contact lens user. She's been using the acceptance of minus 2.75 with minus 1.75 of cylinder at 80 degree of axis in her right eye, and the left eye has minus 3.25 along with minus 1.25 at 100 degree of axis. These are the pentacam maps that I want to share. So we can actually see the central corneal thickness is 493 in right eye and 490 in the left eye. And the K readings are also quite consistent. We can't see any like outliners or any red flags into it. This is the Bellins I want to show. So this is for the right eye that we're seeing, the front elevation and the back elevation maps. Along with this, these are the left eye maps that we have.
I'll be watching your eye first.
We also have the epithelial maps for both the eyes. So we have the 486 of the corneal thickness here, along with the OCT to be normal. And for the left eye, we have 483 corneal thickness, and the OCT looks normal. So over to Dr. Gaurav for starting his live surgery for SMILE for this particular patient.
Thanks, Dr. Amrita. So I think we are all set. Patient is ready. She's a nurse herself, and she's kindly consented to be, part of this live surgery program. So I think the crucial thing is we are using the Visumax laser, which is we've been using for about 4 or 5 years now. And as Dr. Tetial said, we are also now doing predominantly SMILE, although I also do CONTOURA Lasik in good number of patients. For this patient, we chose SMILE. As you could see that the corneal thickness was about 493. Our cutoff for SMILE is about 490. And in these patients, because her correction is just about 3.5 diopters with 1.5 cylinder, we decided to go with a SMILE procedure. Can you look into the light, please? So first thing to do is to make sure what's different with LASIK is that here we want the cornea to be nice and wet, but the conjunctiva to be dry, because this is a corneal suction and patients are very comfortable throughout the procedure. Can you look into the light, please? Yeah, keep watching. So I'm now going to soak on all the extra fluid on the conjunctiva. So I hope my surgical screen is visible to you now, microscope view. So we have to ensure that the conjunctiva is nice and dry, but the cornea remains wet. So we take extra precautions because this is a much gentler suction than happens with most other femtosecond lasers, and patient is actually able to see and fixate. I'm in fact joined here by Dr. Himanshu Mehta as well, who's standing by me to observe, and he's visiting us from Bombay. He'll be operating later on in the day, so we'll take some expert comments from him. Now, once we've done that, we've already primed our cone for the interface for the SMILE procedure, and now I've dried up the conjunctiva, but now I'm going to wet the cornea to make sure that the cornea remains wet. One pickle. So I'll have to focus. So once that is focused, we are all set. We've already primed the pack, and now we'll be going on with the second step of the procedure. So now you'll be able to see a small green light. So you have to look into the green light. So the most important part of doing SMILE is to keep talking to the patient and guiding them what to expect, and that's what we normally do. So I'm going to be talking to the patient and we can all keep hearing. आपको ना ऊपर छोटी सी green light दिखेगी, उसी के अंदर देखना है, वो blink करती रहेगी, and I'm going to count till 10, till 20. You'll be able to see the green light till the count of 10, and you have to only look at that green light. Once I cross the point of count of 10, the green light will become blurry, but at that time then it's important for you to remain relaxed and keep looking straight up as you're looking now. So I'm counting till 20 now. Please keep watching the small green light and relax. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now you won't see the green light, so remain relaxed and keep both eyes open and keep looking straight up. 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So that's the ablation done. So we are using a port of 2 millimeters, and you can as you would like. For comfort, initially when I started, I used to use a 4 mm side cut, and we are used a 6.3 millimeters optical zone with a 7.3 total zone for this patient. And now you have to look into the light. So now I'll be dissecting the two planes. Essentially how SMILE is different from LASIK, as we all understand, is that we don't have a flap, and that is probably the key to all the benefits which accrue from SMILE. So now I'm first identifying the deeper plane, and once that is, and you could see that the OBL was escaped, and this is the sign which Dr. Sheetal has described when you have a good sudden escape of that plane. Now the second plane, which is the superficial plane, so I've identified the cap now, and all surgeons prefer to first dissect the cap. So here we are going to dissect the cap first. And for a LASIK surgeon to switch to SMILE is much easier than it is for a person who has not done femtoflaps initially. Now I've entered the second plane, so now I'm dissecting the deeper plane. And once I've dissected the deeper plane, I will now break through for the side cuts of the lenticule. First of all at 6 o'clock position, and then progressively to the sides, and then identifying on the other two sides and leaving a small frill of attached island of lenticule on each side, which I now break through. So now the section is complete on the right side, and now I complete it to the left side. So now my lenticule is free floating inside. I'm pretty sure that the lenticule has been dissected. Now I'll be using a new technique which I devised a few years back. Most people would remove this lenticule with a forceps. I like to do a hydro expression, although I can nowadays remove the lenticule just with my dissector itself most of the times. But for a beginner surgeon, it would be really nice to use this hydro expression cannula. This cannula has been devised by me in collaboration with Epsilon. So you can see that the lenticule is being expressed out with the gush of fluid, and it's mostly out. I'm doing it very gently. If you push the fluid very fast, it will just come out very fast and then flow away. So now we've got the lenticule out. It's a very atraumatic way of expressing the lenticule using hydro expression, and this cannula is specially designed, as you can see. It goes with the contour of the cornea and gushes fluid at 6 o'clock, and the lenticule will pop out just like SIC as the nucleus pops out. So you can see here that the lenticule, one has to check and make sure the lenticule is complete from all sides so that you don't have any retained lenticule. And once you're sure of that, you can discard the lenticule, and then you can remove the excess fluid from the pocket. So usually patients are very, very comfortable, and the procedure is very quick. Usually within 2 to 3 minutes, the procedure is over. And most patients on day one start seeing 6/6 as well. With patients with high astigmatism, we use cyclotorsion control, and we mark the axis as well. And Dr. Sheetal can probably tell us a little bit more about it. So this was I'm only planning to show you one eye so that we can have some discussion. And the procedure is now complete. We can use the slit to examine the interface for looking for any debris, or even if you want to inspect. So the Visumax has been very good for doing flaps as well, and we have been using this for Smile for a good number of years now, and the results are excellent and patient satisfaction is very good. I'll be happy to answer any questions.
Beautifully done surgery, Gaurav. Congratulations to the whole team for such a wonderful organization. I think it was a really good idea to have live surgery session. What about pure cylinders? Would you want to?
So we've started doing a few pure cylinders now, where what we typically do is on the virion, we are now checking for significant cyclotorsion, because we are lucky to have the virion with us. So we are checking for patients, and if there is, then we would have to do a control of that. And because this option became recently available, and initially when we started off, we were very fussy about, because typical experience said that cylinders may not be great. So we were limiting ourselves to 1.5 or 2 cylinders. Now we are doing good cylinders of 3 to 4 diopters as well. And we have done a few pure cylinders also. But very little experience with pure cylinders, ma'am. And maybe we can hear you and the other panelists for their experience with pure cylinders.
And what is the best thing that you like about this Smile procedure?
Patient satisfaction and doctor satisfaction both. The doctor sleeps well because there is no flap, so I don't have to worry about flap complications. Or I literally have to tell no precautions to the patient, because you don't have to tell them ki aankh ko touch nahi karna, rub nahi karna. And next day, most of them are back to their work. So I think the whole experience, and then the peace of mind that long-term regressions are less and the long-term safety is very good. But I think we can ask our other panelists to tell us a few more things.
Yeah. Dr. Gaurav, beautiful surgery, and I think very nice demonstration of dissection of planes, and very nicely explained about how you don't want to do a complete side cut. Beginners will always have a challenge of flap folding itself, which itself is a challenge. And I would like to ask Rupal ma'am and you, what's the maximum cylinder which can be corrected with Smile 1? 2 is any issues with the steep corneas and flat corneas as far as suction is concerned?
I think Dr. Rupal and Vardhaman can answer that.
You are here. Can you reply? Rohit.
First, congratulations to Dr. Gaurav. I think it was a flawless procedure. Very, very nice. Wonderful docking, wonderful dissection. And I think your pearls about the hydro dissection has been wonderful. And so we also do in some of our cases. Now, one thing as far as the pure cylinder is concerned, I think in the previous Vizumax, I think we were allowed to perform even a pure cylinder without any spherical addition at all. So even if it was a minus 2.50 cylinder, pure cylinder was also possible. But with the new upgrade that they had done about 2 to 3 years back, it allowed us to do much higher spherical correction. But I think pure cylinder was not possible. So we had to add a small spherical bit like 0.25 or 0.5 to do that. Of course, I don't have a huge experience of treating pure cylinders. I think we have treated not more than 2.5 or 3 diopters of major cylinders with a very small spherical numbers, which has been, I think, pretty good, especially with manual cyclotorsion compensation. And of course, Sheetal has done a lot of work on this. We can also add more points to it. And second thing about the steep and the flat cornea, I think as Dr. Rohit has rightly said, we have seen that in especially for the flat corneas, when maybe if the white to white is smaller, the suction is probably slightly more unstable. So we have seen that we have to, as Dr. Gaurav was rightly doing, talk to the patient more, that they cooperate more. We require more cooperation in this regard. So that is one thing that I've seen for flat corneas, not so much for the steep corneas, at least in my experience. Of course, we hardly go beyond 48 diopters, 47.5 diopters, especially with the lamellar procedures. If somebody has 48.5 or 49, then we'll go with the surface ablation. But wonderful surgery, Dr. Gaurav. Thanks for the invite to be part of this.
Dr. Gaurav, excellent surgery. Just one question.
Yes, Dr. Ajay.
What subset of patients do you not prefer to do a smile? Just
so,
for our audience.
Yeah. Yes, Dr. Ajay. So for now, hyperopia is definitely not there. In fact, any patient who is not a candidate for LASIK is not a candidate for smile either. So our cutoff for corneal thickness and everything. But if there was a patient, as Vardhaman said, with pure high astigmatism, I would still think twice. I might opt for a Contoura vision for that patient instead of smile procedure. And also, if I had a very small refractive error, say -1 or less, then I would probably not choose smile. I would probably do a surface ablation or even a thin flap LASIK as well. But for high corrections, I'm very happy to do smile because most studies are showing that long-term stability over 5 to 10 years with smile for high corrections are much better than LASIK. So that's one area. And then of course, anything over 1.5 to 2 diopters, I'm very happy to do smile. And also sometimes, mixed astigmatism, we are still not able to, that's still not available, and hyperopia and these two things are still pending. So we would probably offer LASIK for these patients.